Ladies and gentlemen from around the globe, thanks for tuning in for the third webinar today. Thyroid Federation International welcomes you. It's 10 p.m. in Sydney, Australia, 8 p.m. in Philippines, around 5:30 Nepal, India, in Nigeria, UK, and London, 1 p.m., Ghana, and in 3 p.m. in Kenya, France, Sweden, Italy, Spain, Croatia, Bulgaria, Greece, Germany, Belgium. They're all tuned in. It's 8 a.m. in Canada, in US, in the eastern part, and around 9 a.m. in Brazil. People are tuned in from all over the world on this webinar today. Today is the last day of the 12th International Thyroid Awareness Week 2020. It also happens to be our 25th anniversary. Yes, Thyroid Federation International was formed 25 years ago. Congratulations to all of you. With this seminar and webinar today, we will also bring the 12th International Thyroid Awareness Week to a close today, which is celebrated all over the world with individual countries holding education and awareness programs. As you know, we are going through unprecedented time of the COVID-19 pandemic, and we are leveraging digital means to join together from across the world today to celebrate the 12th World Thyroid Day and International Thyroid Awareness Week. My name is Ashok Bhasin. I'm president of Thyroid Federation International. I'm also the facilitator for this webinar with Dr. Gregory Randolph, who is from the vibrant coastal city of Boston, USA, also famous for its prestigious and top-ranked Harvard University. And Dr. Gregory is from Harvard. I will introduce Dr. Gregory shortly. First, some housekeeping. First of all, the attendees cannot ask any questions verbally. You must text option on your right-hand screen side. You'll see Q&A side of your screen. After Dr. Gregory Randolph's presentation, 4 to 5 questions will be asked. We may have just enough time for that. Please also follow prompts if you want to join toll-free from your countries on the phone. So you can just join by phone too. And go to join in, which is in green color background, and below that you will see join by phone global call in numbers. So click those global call in numbers, and the dial you'll get a dial toll-free number for your country, so you can log in from there. Now I would like to introduce our eminent speaker, Dr. Gregory Randolph, MD, FEBS, Endocrine, FACS, that is Fellow of American College of Surgeons. He's also Fellow of American College of Endocrinologists. He is a Professor of Otolaryngology, Head and Neck Surgery at Harvard Medical School. Claire and John Bertucci, Endowment Chair in Thyroid Surgical Oncology, Harvard Medical School, Director, Thyroid, Parathyroid, Endocrine Surgical Division, Massachusetts Eye and Ear Infirmary, and member of Endocrine Surgical Services, Massachusetts General Hospital, President, American Academy of Otolaryngology, Head and Neck Surgery, 2016 and 2017. With more than 25 years of experience in otolaryngology, Dr. Gregory Randolph specializes in thyroid and parathyroid surgery. He's a thyroid and parathyroid surgical practice, seeing patients and operating at both Massachusetts Eye and Ear and Mass General. He was the first otolaryngologist member of the American Association of Endocrine Surgeons, the first otolaryngologist member and council member of the International Association of Endocrine Surgeons, and the first otolaryngologist and U.S. surgeon to be board certified to endocrine surgery in the European Union. With more than 155 peer-reviewed publications, Dr. Randolph has focused the bulk of his research on recurrent laryngeal nerve anatomy, preservation, and monitoring during thyroid cancer surgery, with a concentration on the importance of laryngeal exams, the recognition of lymph node metastasis, and revision cancer surgery. He's also on the Medical Advisory Board of Thyroid Federation International, which I tremendously like. The list is very long, and perhaps that is just 50% of what you do, Dr. Gregory. Thanks for accepting to be a speaker for the webinar today. However, before I hand it over to you, I wanted to thank two important contributors for the webinar help today. Without the support of Merck KGaA Germany and Porter Novelli, the host of the WebEx, this webinar would not have been possible. So thanks to our Merck and Porto-Novelli colleagues, we will be putting this webinar on the YouTube and our website to those who have missed it can view it later. So both on YouTube and our website. It will also be available in Spanish subtitles later. So now I will hand it over to you, Dr. Gregory and Randolph. The platform is yours.
Well, thank you so much, Ashok, and I want to thank you and your coworkers and the Thyroid Federation International for putting on this wonderful program, this week-long anniversary program to benefit patients with thyroid disease really all around the world. I appreciate the opportunity to speak to this wonderful group, and I want to focus on something that I have been working on for some period of time, which is the relationship between voice and thyroid surgery. There are many different connections between those two, and patients with thyroid disease may often require surgery or are considering surgery, and so this is something I have found over the years to be of great interest to individual patients. I am, as Ashok mentioned, an otolaryngologist, head and neck surgeon. I practice for the last 25 years at the Massachusetts Eye and Ear Infirmary. This is the very first building. This is not the current building, of course, that is along the Charles River in Boston. I also, as an otolaryngologist, work in the Division of Surgical Oncology with my general surgical colleagues and endocrine colleagues at Mass General Hospital. Mass General is known for many different firsts, and this is the ether dome where individual actually had neck surgery with anesthesia given by a dentist, a local Boston dentist. You can see the chloroform, the container holding the chloroform here many years ago. And so I bring you, this is a view from the hospital of the Charles River, and so I bring you welcome from Boston, from Harvard, from the American Academy of Otolaryngology and the American Head and Neck Society. So I want to go back a little bit. Some of the improvements that I've been trying to work on with my colleagues over the years are to reduce the potential for recurrent laryngeal nerve injury, or the nerve that goes to the voice box during thyroid surgery. And some of these potential advantage need to be understood with a historical lens. So let's look at the issue of voice and thyroid surgical complications. Let's look back a little bit first to get oriented. Dr. Bill Roth is a very famous general surgical, really a forefather of modern surgery, including thyroid surgery, many years ago. He published not very long ago, more than just about 150 years ago, his first series of thyroidectomies where 4 out of every 10 patients died. This was for uncontrollable hemorrhage during the surgery. Uncontrollable hemorrhage during the surgery. And also those that did not hemorrhage during surgery were subject to potential infection or sepsis postoperatively. This is another example of how far we've come. Many patients were operated on in the early days of thyroid surgery, not for thyroid cancer, which was really not very well understood back then, but for Graves' disease. There was no other treatment for Graves' disease. There was no radioactive iodine, there was no methimazole, there was no PTU. And so patients either had surgery or had unremitting disease. So patients with surgery had the problem of being operated on while they were not, we call it now, prepared preoperatively. They had flagrant and metabolically unstable hyperthyroidism and then subjected to the risks of anesthesia during surgery, and so would often, in a state of uncontrolled hyperthyroidism undergoing anesthesia, often would go into shock. This was a pneumatic garment that Roswell Park created and was utilized by George Kreil early on to try and prevent peripheral pooling and avoid the issue of shock during unprepared Graves' disease surgery. It has been known for a long time, all the way back to Galen in the 2nd century, that there was this relationship between this structure in the neck which they noticed, if cut, would stop the animal from vocalizing. And so they knew there was some relationship between this nerve and voice. Initially, they thought it was that the nerve was not conducting electricity to the vocal cord. They thought it was some sort of pulley system that would allow the nerve to pull the vocal cord to allow for voice. And so it was also known very early on, as this quote from Gurley emphasizes, that one of the problems with thyroid surgery is the potential loss of voice, la favela, during thyroid surgery. And it was Gurley's judgment that if you really knew the anatomy, which was the point that most of my presentation focuses on, you can preserve the nerve during thyroid surgery. So voice is really what I'm going to be speaking on, the very personal and important function relating not only to many of our human characteristics, but also, importantly, when altered, can alter vocation for lawyers, for teachers, for many of us using our voice on a regular basis. So what is voice? These are the main issues that I'm going to be talking about during this presentation: voice, laryngeal exam, vocal cord paralysis, and then surgery and the professional singer, where we have gotten to today, number 4. So what is voice? Voice is really, the voice box, this thyroid cartilage here is where the vocal cords are. Inside, about halfway down the thyroid cartilage, the Adam's apple is this little notch in the thyroid cartilage. Vocal cords are about halfway down. They represent small folds in the airway that can move. They move and close in order to protect the airway, and they open in order to breathe. They're secondary, and that's probably their first most important structure. They are the sphincter that controls the airway. The second function that has evolved from this sphincter of the upper airway is voice. And so voice, really, normal voice, is the passage of exhaled air through the partially closed vocal cords. It is subtle shaping, changes in length, changes in subtle position, changes in subtle degrees of tension, which are under nerve control that allow for voice. And I'll show you a video that will make this clear. Here is an example of, this is an opera singer that we did an exam with a fiber optic scope through the nose looking down at the vocal cords. So I'll orient you towards this video. Here is the epiglottis, the front of the larynx. Here's the left vocal cord. Here's the right vocal cord. And you can see the whole throat moves quite a bit, but the action is really down here at the level of the vocal cords. So really pretty remarkable. It isn't just a simple movement of the vocal cords in and out, but very subtle changes in the tension and muscular control of those vocal cords that allows for all of the variations that we know of voice and singing. This is a little different than hoarseness. Here is the right vocal cord in another patient. Here's the left vocal cord with a large benign polyp on it. So this is a structural abnormality of the left vocal cord, and you can see because of that structural disturbance, the voice here is very hoarse. You don't have two crisp edges of the vocal cords to work together. Both vocal cords are moving normally, though. And this is the nerve, the thyroid cartilage that I told you about here, the Adam's apple here. This is the second cartilage of the voice box, the cricoid cartilage. And in black are the nerves that come from the brain down on the left side, travel down around the aortic arch and go back up to the voice box to enter and innervate the left vocal cord, and its partner on the right following a slightly different course, going back up this right recurrent laryngeal nerve to innervate the right vocal cord. And these nerves create two different motions of the vocal cords. one set of motions is to move the vocal cords apart. That is, when we gasp for breath, the vocal cords open up. And then when we speak, the vocal cords close together. It's interesting. You would think that the bulk of the nerves, bulk of the muscles would create opening to allow for breathing, but actually the bulk of the nerve fibers and the bulk of the muscle fibers relate to muscles that close the larynx that relate to voice. So evolutionarily, voice seems to be even more important than breathing. That is, to scream at the bear that's chasing you seems to be more important than opening up the vocal cords and running away from the bear. That's an interesting thought about humans and how we've survived. This is a view, a kind of 45-degree angle view of the larynx that shows this is the thyroid cartilage, but the left thyroid cartilage has been removed. And so you can kind of look into the larynx and see the left recurrent laryngeal nerve here and the right recurrent laryngeal nerve here. And these are the two vocal cords that you saw from above, from a view here in those videos. So what about looking at the larynx, and why is that important? So it turns out that voice symptoms can diverge from vocal cord paralysis. So you can have variable function remaining in the opposite vocal cord, you can have variability in the position of a paralyzed vocal cord, and you can have variability in contralateral vocal cord compensation. So you may have dysfunction of one of the vocal cord nerves, and symptoms may or may not reflect that. It's because of all of these factors. And so it's important for us as otolaryngologists and as thyroid surgeons to look at the larynx before and after surgery to really know the status of the larynx both before and after the surgery. The two main ways we do that are with looking with that scope that I just showed you a video of. It shows the vocal cord movements in great detail. And there are other acoustic analysis measures that we can apply to voice also that give us information about the functioning of the voice. Why is it so important, say in the setting of thyroid cancer, for us to know about the functioning of the larynx? Well, here's a picture from the operating room of the trachea, and here is the right thyroid lobe and a right thyroid mass with the recurrent laryngeal nerve right here, that black line that I showed you on the previous diagram, and it is going right into the mass. The cancer, which I'm outlining here, is invading into the nerve. So this nerve here, you can see this is the cancer here on a photomicrograph of the cancer once it's removed, and here's the nerve that had to be sacrificed, goes right into the cancer. So the importance of vocal cord exam is that when we have this sort of situation with vocal cord paralysis, we want to know about that prior to surgery. So we want to know about laryngeal exam and voice because of the potential for cancers that can invade the nerve and cause vocal cord paralysis. Also, we want to look at the larynx because surgery itself can cause vocal cord paralysis. There are many different studies looking at the rates of recurrent laryngeal nerve paralysis after thyroid surgery. These are some of the factors involved, but the bottom line is it's almost 10% of patients in some studies that may have some alteration in the motion of their vocal cord because of some nerve dysfunction after thyroid surgery. So we feel that both pre-op and post-op laryngeal exam is very important. Laryngeal exam is important preoperatively for these reasons, mainly the detection of invasive cancers which can invade the nerve, and then postoperatively it's really considered one of our main quality measures, quality metrics of surgery to determine whether vocal cord paralysis has occurred or not. There are guidelines that the American Academy of Otolaryngology have offered to oversee this whole process of who requires vocal cord evaluation, and there are numerous key action statements in this guidelines, important guidelines document. Now, let's talk then about vocal cord paralysis. So you've heard a normal larynx, you've heard a normal voice. Let's talk about vocal cord paralysis. This is a picture of when vocal cord paralysis, say we're operating on this left side and this is the left vocal cord, you see what happens if that nerve is, say, cut during surgery. You can see that then the muscle that is that left vocal cord that the nerve goes to becomes atrophic. It no longer moves, and it becomes flaccid and sunken. And so that is the view of a left vocal cord paralysis. It's no longer straight, it no longer moves, it's bowed, it's sunken in. And so what happens is the two vocal cords then cannot close when we speak. And so voice weakens as air escapes because of this change in motion and shape of the vocal cord. And so the voice becomes a whisper. There is air escape. Instead of the two vocal cords coming together tightly and phrasing that exhaled air, then you lose that valve. The valve is open while you talk. And so I have a demonstration of this in a patient who had the misfortune to have a thyroid surgeon alter the nerve right after surgery 4 months ago. But again, I wasn't aware of it. So this isn't a malfunction of our operating system. Ashok's got a good webinar here. This audio is fully on. The problem is her voice has been unplugged and become breathy because of the vocal cord paralysis. That left vocal cord paralysis no longer allows her to close the voice box. And here's a perfect demonstration of that occurring. That left vocal cord paralysis is not able to close the larynx anymore. Nicely demonstrated. And so let's talk now about the last thing, is that how can we make this better? What tools do we have now that can allow us to operate on everyone, including even patients who are professional singers, and try and get the best outcomes? What advances do we have? And I would say the first one is the recurrent laryngeal nerve monitoring. That is, here's the thyroid, here's the left recurrent laryngeal nerve going into the voice box right there, and this is an electrical probe that allows us to stimulate the nerve, and we can measure the response of that stimulation with electrodes within the larynx. This gives us another tool, a wand, to allow us to identify what is the nerve, what isn't the nerve, and is the nerve still functioning. This is called recurrent laryngeal nerve neural monitoring. It is done with recording electrodes. This is the endotracheal tube that patients have for thyroid surgery, and so there are electrodes that are put on the side wall of the endotracheal tube that allow us to record that vocal cord depolarization when we stimulate the nerve. This monitoring has been discussed and recommended in that guideline statement of the American Academy of Otolaryngology that I showed previously, and they recommend it for bilateral surgery, revision surgery, and surgery in the setting of preoperative vocal cord paralysis. And so what really monitoring does is you still need to be a good surgeon, you still need to visualize the nerve, but it provides more information than just is what apparent visually. It provides electrical information during the surgery. For example, this is a view of the left recurrent laryngeal nerve at surgery in a thin woman. And so you can see the nerve is not very apparent here, but here, that's the nerve. The nerve in thin women can be a very thin, small caliber finding that visually can be very unclear. And so there are guideline statements that we have generated through our International Neural Monitoring Study Group that relate to how you should set up the equipment and exactly the parameters that would be most important to utilize during thyroid surgery with neural monitoring standards. And basically what you get when you stimulate the nerve is you get this waveform, which is the depolarization of the vocal cord of the nerve that you're stimulating. And there are normative parameters that we have created for the various nerves in the neck that are encountered during thyroid surgery so that we have the normative corridor or the normative set of data that should occur in nerves that are functioning normally. And we have also created summated data that allows us to look at basically kind of the normative corridor. This is the beginning of surgery here, this is the end of surgery here, and these are the normative or green corridor through which you should travel during surgery to make sure that if you have all of these parameters, if all of your nerve stimulation parameters are within this corridor during surgery, then you are assured that vocal cord function will be normal postoperatively. One thing I wanted to increase our awareness of voice during thyroid surgery is that it isn't only about the nerve to the voice box, the recurrent laryngeal nerve, but the external branch of the superior laryngeal nerve, a second nerve that is at risk during thyroid surgery, is also very important. This is a smaller nerve that comes from above down to the larynx, unlike the recurrent laryngeal nerve, which comes from the chest up to the larynx. The recurrent laryngeal nerve, the nerve I've discussed so far, is certainly the main nerve that is important for vocal cord movement inward to speak and movement outward to breathe. But the external branch of the superior laryngeal nerve, this smaller caliber nerve that comes in from above, is also very important for especially high pitches and for vocal projection. What this nerve does is it comes from above and it innervates this muscle, the cricothyroid muscle, which allows for a forward shifting of the thyroid cartilage relative to the cricoid cartilage. And so what that motion does is it stretches the vocal cord. And that's why this nerve and the muscle that it innervates is important, especially for high frequencies and for vocal projection. This nerve is actually has a pseudonym for it's the nerve of Amaletta Galli-Circe. This is a famous opera singer who was known for her high registers, who had thyroid surgery back in the 1930s, and we think perhaps had an injury of the external branch. And so the papers, the newspapers after her surgery said after her surgery that the surprising voice is gone forever, and described it quite poetically, this loss of the high frequencies and the vocal projection that the superior laryngeal nerve, when it's intact, allows. This is just a reminder, a little video, audio clip of her singing prior to her injury. And this emphasizes her ability to hit extremely high notes and to vocally project her voice, which we feel are functions allowed her by normal superior laryngeal nerve function on both sides. The loss of that is what occurred when she had her thyroid surgery with injury, we think, of the superior laryngeal nerve. I mean, it is really remarkable the extent of her abilities, but again, that high tones and vocal projection are important for many of us, for individuals in business, using their voice to speak to individuals, teachers, lawyers, many people who use their voice. And so we've studied this nerve too with electrical monitoring, and this nerve, just to show you the anatomy, I've shown you previously the recurrent laryngeal nerve, but here is the external branch of the superior laryngeal nerve coming from above. Here's the thyroid cartilage, again, which we've used during this talk to get oriented to. Here's the thyroid notch, or the Adam's apple, and here is that nerve coming down to innervate that smaller muscle that slides the larynx in the way I described, the cricothyroid muscle. And so here is the thyroid gland, the upper portion of the thyroid gland, so you can see how close the thyroid gland is to that much, much smaller nerve, which is very much at risk during thyroid surgery. So now how do we put this all together? Can we do surgery in people now and preserve their voice? I want to just show you a series of patients that I've operated on that are all professional singers. This was a group of 30 individuals. We offered them various indices of vocal health prior and after the surgery, and these were everything from Motown singers to musical theater to Jewish cantor to classical operatic singers. And all of these had both pre and post-op vocal cord function was normal in all these patients with neuromonitoring, and the vocal instrument showed no significant differences pre and post-op. So with good surgical care and with neural monitoring, you can even operate on patients like amyloid Gaucher C and have a good long-term vocal cord out. These are the pre and post-op vocal instrument measures that are offered to these patients that show no difference before and after surgery. So I just want to say that our unit works both in Boston but also around the world. This year we have activities that had been planned for Pakistan and Algiers and Dhaka, bringing this information about thyroid surgery and neural monitoring all around the world. This is an example of one surgical mission that we had in Chikadara, India, which is a very mountainous rural area. This is the hospital right outside the hospital that you see on the right, and this is one of the really massive goiters or benign thyroid enlargements that we see and need to operate on to preserve the airway in some of these patients. This is the instrument room that sterilizes the instrument in this hospital, and basically this is the waiting room for the patients as they come in. These are the two books that our unit have written. The one on the left is surgical text that is now in its third edition that has just come out this month. And the second is a book devoted solely to the recurrent laryngeal nerve and superior laryngeal nerve that focuses on all aspects of those nerves. So I want to also thank again the Thyroid Federation International and Ashok for his wonderful mastery in managing this organization and helping to gather physicians from all over the world to mediate the important educational needs of all of the patients all around the world that constitute the Thyroid Federation International. I want to let you know that Ashok and I are working together on the World Congress on Thyroid Cancer, which is now planned for its fourth iteration in 2021 in Boston in the summer, next summer, Boston 2021. And Ashok and I are coordinating patient information. This is a conference for surgeons and oncologists and endocrinologists that are managing thyroid cancer, but Ashok and I will coordinate making sure that all of the information here in our World Congress next summer is articulated to all of the important patient members of the Thyroid Federation International. And so with that, I'd like to now sign off again to Ashok, who will take it from here and then coordinate a question and answer section. Thank you so much for your time.
Thank you, Gregory. That was wonderful, succinct, very clear. And I think I was reading the comments from other people here that you were very clear and very well understood by the people. Now, we have a few questions here, Gregory. How do I make sure my surgeon knows how to protect my superior laryngeal nerve before I get my surgery done under my surgeon? I am thin, just 95 pounds in weight.
Yeah, so I think it's very important to develop a good relationship with your surgeon, and that means, I think primarily for me, spending time with patients preoperatively. So when I see a patient, even a patient that needs to have thyroid surgery, I like to see them both in the initial consultative visit where we discuss their problem and make a decision for surgery, but then I also like them to come back for a separate preoperative visit prior to the surgery, simply to revisit issues relating to surgery, and really more than anything to allow us enough time to think and discuss all the issues that are important that I need to convey to patients and that patients would like to discuss with me. So I would say you need to talk with a surgeon who is giving you enough time to have a good relationship so that you feel comfortable with he or she operating on you. You know, as a surgeon, you really, as a patient, you need to be thinking really about two things for a surgeon when you meet with them. The first is you need to have some sense that they are able to do the surgery well and that they have expertise in this particular surgery. And usually patients will get this indirectly by their primary care physician or by their endocrinologist recommending. So the patient may not necessarily have any direct information about how expert this individual is. So you're reliant on the physician referrals. So as a surrogate for that, I mean, obviously you trust the individuals that have referred you to the surgeon, but one question you can ask the surgeon to get a sense of, are they really expert in thyroid surgery, is this a focus of their practice? What volume of thyroid surgery do they do? This is an important issue. It doesn't mean that everybody has to go to surgeons that only do thyroid and parathyroid surgery, but you want to make sure that they're doing thyroid and parathyroid surgery as one of their dominant focus in their practice. That way they can be aware of, for example, details like nerve monitoring and be aware of the superior laryngeal nerve. You don't want to go to someone who only rarely will do thyroid surgery and isn't primarily focused on it. So that's your assessment of their clinical acuity or ability to do surgery is the first one. The second one is you just have to spend enough time with that person to look in their eyes and make sure that you as a human connect to them and that you feel this is someone who is moral and going to be fair, able to communicate with you and take good care of you while you're asleep under anesthesia. And that's something you don't need anybody else to tell you. That's something that you get a sense of by simply spending time with that person. But again, a person who is going to take good moral care of you is willing to spend the time with you so that you have enough time to be able to really get comfortable.
Okay, thank you. There's another question, Gregory. If I have a surgery and my voice is altered, what do I do?
Right. So I didn't go into too many of the details here, but I would say there are two potential thoughts if the voice is not perfectly normal postoperatively. The first is there are other factors other than the nerve that could be paralyzed that can cause voice abnormalities. Just having the endotracheal tube down for a period of time can roughen up the vocal cord, kind of like that vocal cord polyp that I showed roughed up the vocal cord surface, and that can give a coarseness or some alteration to your voice. That's the sort of thing that usually gets better within a week or two after the surgery. And usually the changes in the voice are kind of more intermittent and relatively mild in that setting. That is where it's simply because of the intubation of the larynx. If there is true vocal cord paralysis, again, the symptoms are usually a little greater, and the symptoms, like I said, this kind of whispered quality to the voice. It's not so much a coarseness, it's a reduction in the strength, an open valve. That if you have a little bit of that, and if you have a little bit of coughing when you drink liquids, which is the other thing that can come from vocal cord paralysis, then you really want to seek out your surgeon and make sure that they can look with a fiber optic scope at your larynx at some point postoperatively to make sure that the vocal cords are moving normally. So if there's so that's what you do in terms of evaluation. Give minor changes a little bit of time, persistent weakness to the voice, bring to the surgeon's attention so that they can examine your larynx. If there is someone who has a larynx examined and is found to have vocal cord paralysis after surgery, then you really need to go to the specialists who manage that sort of problem, and that is an otolaryngologist, head and neck surgeon. There are some otolaryngologists who specialize in just the larynx, called laryngologists. That's a subgroup of otolaryngology, and they have all of the abilities to evaluate you and determine if anything needs to be done. Sometimes vocal cord paralysis can get better on its own without doing anything. More recently, we feel that in general, many patients are benefited, even those that might have a spontaneous return of their vocal cord function in the short term to optimize normal subglottic pressures and reduce aspiration. transient vocal cord paralysis can be managed with a vocal cord injection. I'm not going to get too much into that, but it's a very minor treatment which can improve symptoms in the short run. And so this new treatment, which is very minimally invasive, is a really good idea for patients with vocal cord paralysis, even those where it might improve on its own. So basically, if you have a documented vocal cord paralysis, you really want to get to an otolaryngologist to have them examine you and take you by the hand and manage you. And there are some very successful management strategies.
Thank you. There are many surgeons also on this webinar. I'm the president of Thyroid Federation of India is a surgeon, and he does a lot of surgery. He knows you too personally. I think a lot of people are going to benefit from this. Other question is, I am a teacher, recently diagnosed with Graves and hyperactive thyroid. I am advised to remove my thyroid. What should I do to ensure my voice remains intact? And do I get a video in the end to show how it was all done?
Well, I would say we've covered the issue of, making sure the people who are referring you to the surgeon understand the quality of that surgeon. When you go and see the surgeon, as I mentioned, to discuss with them, is thyroid surgery a focus of your practice? Is that something that either you only do or one of your main surgeries that you do? Those would be key questions. Again, having a good relationship and rapport with communication with the surgeon, I think, is very important. In terms of documentation postoperatively, that's something, the degree of documentation is something that you should discuss with the surgeon. I would say that we don't know what would happen in the future, but I would say right now it is not a common thing to have a surgeon provide a video of the surgery to the patient postoperatively. I'm not criticizing that if the surgeon and the patient feel that that's the best way to go, but I think to a certain extent, the real optimal pathway is to develop a relationship. Remember that second part of what I was saying, that you have to have a moral connection and a good team trust with the surgeon, so that you may not need a video. If you have that good relationship with the surgeon, they're a high-volume surgeon, they focus on thyroid surgery, and you have good trust with them, I think that's really what you should endeavor towards. I'm not so sure that getting a video at the end of the surgery is something that would be important. I'm not saying you can't discuss that with your surgeon, but I don't know that I would recommend that.
Okay, thank you. I'm an aspiring singer in my 30s recently. Some tumor was noticed near my vocal cord. What is your advice to ensure I do not lose my voice due to surgery? I have been a smoker for 10 years, but I've left it 5 years ago.
Yeah, so it's not clear to me when you say a tumor that was near the vocal cord, it's not clear to me whether that would be two separate things. If, like the picture I showed, there was some growth in the thyroid lobe near the nerve, then you would need to get very good head and neck surgeon looking at you and get some imaging to make sure that that lump in the thyroid was not potentially invading the nerve. So imaging would be very important there. But I'm not sure, based on your comments, whether you might be dealing with some mass or lesion of the voice box itself. And so that would be something where you would need to visit an otolaryngologist, and they would need to examine your voice box to determine whether the tumor was in your larynx or not. That's a separate problem, which I have not discussed today. That's a mucosal lesion of the voice box that can be from spontaneous cancers of the larynx, of the lining of the larynx, or cancers that may be induced by smoking or drinking alcohol. You can have it without smoking or drinking, but those are separate. I've not discussed those today. They do affect the larynx, but they affect the larynx primarily as a lesion of the voice box. They can certainly affect voice because they affect the larynx, but that is not the picture that I was showing. The picture I was showing is a thyroid cancer that was invading the nerve in the neck. and because it invaded the nerve, then that nerve was not able to innervate the vocal cord and cause vocal cord paralysis.
Thank you very much. I think that's enough time that we have. Thank you very much, Dr. Professor Gregory Randolph. That was a great insight. And I'm sure our TFI members of Thyroid Federation International the world over will appreciate what you've done this today for us. Before I close the session, today some important announcements. I wanted to take this opportunity on behalf of Thyroid Federation International to thank Dr. Gregory Randolph from Harvard School of Medicine. I wanted to thank Exelexis, Horizon, Merck KGaA, Germany, for their support on the International Thyroid Awareness Week, and Porter Novelli on the WebEx support and putting the lecture together for the YouTube. That's all for today, folks. Today is May 31st, 2020. Thanks, everybody, for joining in today. Keep the education and awareness effort going during this week. And most important, keep safe and keep healthy. Thank you. Bye-bye.
Be safe.